Good morning, everyone. Today we are going to be talking about strabismus. I'm Professor Al-Hazza, the director of your block. We are going to have a total of 6 lectures. We've already finished the 4 lectures, which was the orientation and instrumentation, the visual impairment, and this now is going to be your 4th lecture, which is on strabismus, which some people can find it a little bit complicated, but I am going to totally simplify it and make strabismus a really nice way to understand the muscle imbalance. And we're also going to be talking about amblyopia and about certain pediatric diseases. So we're going to talk about the definition of strabismus. We're going to be talking about the classification of strabismus, the etiology and causes, epidemiology, the clinical features, mode of presentation, just a simple examination and diagnoses, and then just the basics of management and early detection, because we're going to be talking more about that, hopefully, when I see you in your 5th year medical student. So what's your normal visual acuity? You get asked that a lot. I'm sure you'll be asked by your parents as you become a doctor. So the vision in childhood, usually when they're born, when they're first born, a child's vision is 2400, and we explained that in the orientation. So it's usually 2400, and then there's a rapid development over the first 2 years, and usually by age 2, as you see here, usually by age 2, the patients are 20/20, which means 6/6, normal vision if there is no other problem. This, we're talking about a normal child. What is a normal binocular vision require? When we say binocular, we're talking about both eyes, binocular, from the word two. You need normal eye movements. You need straight eyes. You need good vision in both eyes. You need a symmetrical refractive errors. Whatever refractive error you have, they have to be similar so that not one is different from the other. And you have to be able to fuse the images of each eye and focusing of the images on the retina. So here is an object or an image. Both eyes have to be symmetrical. They both have to have good vision, and they have to be able to fuse the image together in order to have normal binocular vision. So when we talk about strabismus, there are many names for it. It can be called a squint. It can be called a crossed eye. Some people call it a crooked eye. But I think you see very nicely here, this is a straight eye. And please concentrate on, we're going to be talking more about this later, about this corneal light reflex as you see here. And this is smack in the middle. The pupil is right under it. If you look at this light reflex, unfortunately, it's way out here. It's way out here in this eye. So these are non-symmetrical or non-equal. So when we talk about strabismus, what we say, it's an ocular misalignment, meaning the muscles are not aligned, they're misaligned. Another nice term for it is extraocular muscle imbalance. The muscles are imbalanced. And if you look again here, here is your center. And look at this. Here we actually have two or more corneal reflexes. So if you look at it, And you look here, this is one, this is the other. It's actually out on the limbus. We talked yesterday about the definition, or the day before yesterday, about the limbus. So it occurs in about 2% of children who are under 3 years of age. That's considered a lot. So for every 100 children born, there will be 2 children that will have strabismus. Male and females are equally affected. I put this up just to simply show you the different extraocular muscles and what each one does, okay? So these are your 6 extraocular muscles, as you see nicely here. And this is your gaze of movements, what it requires. Usually there are 2 muscles working together. You don't have to worry about that. All I need you to know is there are 6 extraocular muscles. So there is an inherited pattern. We really don't know the details of it. We cannot identify it exactly, but usually one or both parents are affected. And sometimes siblings. These are all siblings who are all wearing glasses. And here's 2 other siblings, as you see. Here is your strabismus in this patient, and here is the strabismus in this patient. So sometimes there is a family history, but I will tell you the majority, there is not. It could be only one child affected in the family and no one else is affected. So what's the definition of strabismus? When we define strabismus, it's a manifest deviation or misalignment of the eyes. It's a disorder in which one eye misaligns with the other when focusing in a primary direction of gaze. Let's show you the normal. Here's the normal. There's an object here. This eye sees this object. This other eye sees this object. So technically they meet together at the object. So this is what we call alignment. These 2 eyes are actually aligned. When we say misalignment, this eye is actually seeing the object, but unfortunately, the other eye is misaligned and does not meet the other eye, as in this image, but actually it crisscrosses and does not meet. This is when we call it misalignment. I'm really trying to make it very, very simple for you to understand. So let's define strabismus. It's an imbalance in the normal tone or coordination of one or more of the extraocular muscles. And as I mentioned to you, we're going to be showing you more. There are 6 extraocular muscles, which result in a deviation of the affected eye. You can see it here. One eye, this is your corneal reflex. It's just simply by using a pin light. You can see it's centered in the pupil. Here, unfortunately, it's right here at the limbus. You can see that little mark there. So this is an imbalance. When a significant ocular misalignment exists in childhood, the brain developing visual system does not acquire binocular vision. Remember, we talked in the beginning. Binocular, both eyes have to be aligned, symmetrical, good vision. And here again, we're seeing another. Here's your corneal reflex, and here, unfortunately, it's way out towards the temporal side of the eye. So let's talk, let me spend just a couple of minutes talking to you about the muscles, the extraocular muscles in the eye. There are a total of 6. Please know them. Superior rectus, inferior rectus, medial rectus, lateral rectus, and then I've highlighted the 2, the superior oblique and inferior oblique, because they're a little bit different from the others, and we're going to be showing that. So this is your left eye, as you can see, because here's your canthus. This is your nose here, and these are your 6 extraocular muscles. So the 6 muscles in each eye, they control the eye movement. So these are your muscles. They move your eye to the right, to the left, up, down, and diagonally. There are also 3 cranial nerves that also control the muscle action. Cranial nerve 3, 4, and 6. The way to remember which muscles they supply, just always remember the 4 is SO4, superior oblique, so SO4, and the 6 is LR6. All the other muscles are controlled by the cranial nerve. That's how you remember them. SO4, LR6, and the rest are by the cranial nerve 3. So we talked about, this is where mix-up always comes between the medical students. We talked about 6 ocular muscles, but now I am going to talk to you about the normal eye movement. Remember, there are 9 cardinal eye movements. You don't have to know what they are in details, but do know that they are 9, whereas we have 6 extraocular muscles. So we're talking about 2 different things. These are the muscles, as we mentioned, 6, and these 6 muscles actually they result in 9 cardinal eye movements, as you see nicely here. This is your normal. Then you have your up and right, up and left, right. And here we're holding up, of course, because they're looking down. So here down and right, and down and left. So we have 9. There's something called, before I continue with strabismus, there's something called pseudo strabismus. Anytime you put the word pseudo, means false. So a child may appear to have a turned eye or a strabismus or a misalignment, and simply look at your corneal light reflex here. You can see it. This is smack in the middle, and this is smack in the middle of your pupil. So this is your corneal light reflex test. This is a normal one. It's in the middle of the pupils. When you have a pseudostrabismus, although it might look to the parents and to the relatives, or even to the doctor who's not ophthalmologist, that he has strabismus, but if you look at the light reflex, interestingly, you will see it in the middle, again in the middle, again in the middle, and again in the middle. So what causes you or the parent or the non-ophthalmologist to think this patient has a strabismus? It's a pseudostrabismus. A lot of times, the epicanthal folds, we may talk about, as you see very nicely in this patient, and in this patient even more. So the epicanthal folds, when the child is born, they can be extra. We talk about epicanthal fold, it's just an extra skin that covers the inner corner of the eye. So you see it very nicely here in this particular patient, and right there and right there. So it covers the eye. It's actually covering the right eye more. So you think there is a strabismus. Also a broad, flat nose. You see, this nose is broad and it's flat. And because of that, you think there is a strabismus. And sometimes the eyes can be set either close together, as in this patient, or they can be far apart, as in this patient. So all these refer to pseudostrabismus, but please look at your corneal light reflex. It will be smack in the middle, and you will know about that. So what's our classification of the squint? You can either have the eyes coming in, so we call it esotropia. We can have the eyes going out, so the eye is in, esotropia. The eye is out, exotropia. The eye is up, hypertropia. The eye is down, hypotropia. When we say esotropia, it's simply, when we say esotropia, it's just a conversion. It's conversion. It's derived from 2 Greek words, es, meaning inward, and trep, meaning turn. So it's turning inward, and you see it very nicely here. Again, look at your corneal light reflex, right in the center of the pupil, and here it's more towards the limbus. Esotropia, the eyes are crossed. One eye looks straight ahead, as you see here, really nicely. So this eye is looking straight ahead. And the other eye is turned in towards the nose. Very nicely seen here. I'd like to talk a little about accommodation because that can kick into esotropia. So let me spend a minute or two, although you should have taken it in your physiology. Remember we talked about the ciliary muscles before, but when we talked about the ciliary, we talked about this, it was in a different context. So when you accommodate meaning being able to look near. You accommodate when you read, when you look at something near. These ciliary muscles actually contract, and you see them here. This is your normal muscle. These are relaxed. So these are your muscles, and they're relaxed. And this is your lens, and they're just relaxed. When you accommodate, or when you look near, what happens is your ciliary muscles, as you see very nicely, here, these muscles contract. And when they contract, the lens actually takes a different contour, as you see very nicely here. So the lens rounds to a greater strength to be able to read or see something close. If you look at the lens here, it's like it's sleeping. Here, it's actually contracted. And this is what we're doing here. So when we're looking at a distance, as you see here, the lens is flat. The iris or the ciliary muscles are actually relaxed, and you concentrate the image on the retina. But when you're looking at something close, remember this is infinite. When you're looking at something close, your ciliary muscles contract, your lens contracts, and then it's actually the image comes closer to the retina. So what it does, it causes the natural lens in the eye to change its shape. And it allows the images, as we showed nicely here, it allows the images to focus properly on the back surface of the eye. So a child who is hyperopic, remember, I'm sure you've taken that, you have more or less 3 refractive errors. Hyperopia, so you put plus lenses. Myopia, you put minus lenses. And astigmatism, that's a different story. So you have 3 refractive errors. So a child who is hyperopic, we call it farsightedness, usually does not have a blurred vision. They don't have, because they weren't looking. But in some children who are hyperopic, this accommodative effort, when we say accommodative effort to be able to look to near objects, is associated with a reflex crossing of the eye. If you look at this patient here, when he's trying to look at something very near, and when he does, his eye goes in. And you have to remember, with children, their world is right under their nose. I mean, everything is close by. They don't tend to look at a distance. You know, he looks at his mother's face, the mother's breast, his bottle, his little game. So everything is around him. So he's continuously accommodating. And sometimes these children, when they accommodate, because they're remember, they're hyperopic, they become strabismic. And here we see this patient straight. She's trying to look near, and unfortunately, her eye crosses in. So this is what we refer to as accommodative esotropia. I will not ask you about it in the exam, but the reason I bring it up is because I want you to understand accommodation and not accommodative esotropia. So it's caused by hyperopia. We talked about farsightedness. There's hyperopia, myopia, and astigmatism. And these children who are hyperopic easily and automatically focus on objects at a distance and near through accommodation. So when you look far, you're fine. But when you look near, it's accommodation. And usually, here we go. Here's this patient. You see the nice corneal light reflex in the middle. And here it's towards the limbus. So you know that he has esotropia, but we put the right glasses on and we bring his corneal reflex to the center. We're going to be talking about management treatment. And usually the age of onset is between 2 to 3 years of age, but don't worry about accommodative esotropia. All I need you to know is what is esotropia. Next, we're going to be talking about exotropia. It's derived from two Greek words, ex meaning outward, trep meaning turn. So for exotropia, it is a divergent. So here's your normal eye. Remember, we talked about the corneal light reflex. Now this one, it's towards the limbus towards the nose. So you have it inwards. Again, here's a patient with an exotropia. It's smack in the middle. And here, unfortunately, it's towards the limbus, towards the nose. So it's going out. The eye is going out. This could be an interesting multiple choice question. So the eyes are crossed. One eye looks straight ahead, as you see, and the other eye is turned away. One eye looks straight ahead, corneal light reflex. The other eye is turned away from the nose. Hypertropia, that's a vertical strabismus, and it's a vertical misalignment of the eye. All I need you to know is the fourth nerve. Remember, we talked about the superior oblique. This is what we refer to as superior oblique palsy. You don't have to worry about it, but just remember that for the hypertropia, it's the fourth nerve. Nothing more than that. Fourth nerve palsy, smack in the middle. This is actually the eyes going up. So the corneal reflex is going down. Again, it's in the middle and it's going up. Then, so when we talk about hypertropia, vertical strabismus, what are the causes? Thyroid-related eye disease, orbital trauma, Brown syndrome, and sometimes following eye surgery, God forbid. It's just simply telling you. And again, here's another patient with a hypertropia. Hypotropia is different. It's also a vertical strabismus, but this is when the eye deviates downwards. So in comparison to the other eye, what are your causes? It could be due to your nerve palsies, thyroid disease, stroke, trauma, neurological disorders. Just remember there is a vertical strabismus and we won't be worried much about that. Well, now let's talk, why do we get strabismus? Why does a child develop strabismus? Remember we talked about refractive errors. The refractive errors are three. You can either have hyperopia, myopia, or strabismus. So usually when a patient has a high refractive error and it's uncorrected, unfortunately, when it's uncorrected, they develop strabismus. So you put the glasses, you refract them, put the glasses back on, and you get a nice corneal light reflex. What's another cause of strabismus? So we talked about refractive errors. Another cause is any ocular conditions, but it has to be uniocular. So it's a uniocular, one eye, dense opacity or pathology in children. Nicely shown here, corneal opacity. So anything, remember we talked about the visual axis, we talked about the visual pathway in our first lecture. If anything deprives of the light going in and reaching the retina to reach the brain, and an important cause is what we refer to as corneal opacity. It will not allow the light in. Another cause is cataract. Unfortunately, here's a patient with cataracts. This is bilateral. Usually it's a uniocular. And any macular disease, anything. So the light goes through the cornea. Remember we talked about from the cornea to the pupil into through the lens and the vitreous, and then goes on the macula. Here it went through all these, but when it reached the macula, it found out that the macula, there is pathology, disease, so it did not take it from the macula to the brain. So what are the common ocular conditions causing strabismus in ocular conditions? Retinopathy of prematurity. If a patient is not able to see because of retinopathy of prematurity, he will develop strabismus. Retinoblastoma, we're going to be talking about that at the end of this lecture. The retinoblastoma, which is tumor of the eye, will also cause that. Anything that causes brain injury. Hemangioma, can you see it here? This hemangioma is closing the eyelid, not allowing the light to go in. Therefore, it will also cause strabismus. Certain certain congenital cases and hereditary congenital cases or genetic cases, trisomy 18, congenital rubella, cerebral palsy. These are all causes. So what's the etiology of the strabismus? Sometimes you might find family history. So sometimes of strabismus can run in families, and it's really present mostly as inherited cases. But remember, we said this is not the common, but I also bring it up. Acquired strabismus, meaning the patient developed something after they were born. Trauma. Sometimes when you have trauma, extraocular muscle lesions. The most important is your third cranial nerve. Your third cranial nerve, and we're going to be talking about that when you come to your fifth year and some in the systemic, is when unfortunately you have a ptosis and your eye is down and out. So these are the acquired strabismus. So what's the epidemiology of strabismus? It shows that premature infants, so we talked about retinopathy of prematurity, and unfortunately the mentally handicapped are highly affected when you compare them with the rest of the population. And interestingly, strabismus is more prevalent in the Africa than any other continent. So we tend to see it a lot in our part of the world. What are the clinical features of strabismus? So someone that has strabismus, you can see this patient here. This is in the middle. This eye, it's the corneal right reflex is going towards the limbus. Unfortunately, what do you see in this patient? They have an abnormal head position. Can you see that? Here's an abnormal head position. What they're trying to do is they're trying to move the image from the poor vision from the deviating eye. And sometimes, again, an abnormal position, he has his head down. And this one, as you can see, he has his head up. All they're trying to do is trying to get the light into the retina to reach the brain. So these are your modes of presentation of strabismus. They can have diplopia, they can have a headache, they can have reduced vision. Sometimes these patients will have lack of concentration, and the teacher will always complain that he is not concentrating. It's simply because he has a strabismus and cannot really focus. And then they can also have neck pain. So you look at this little boy, you can see turning his head just to be able to remove this ocular misalignment. I like this picture. This is the patch, and we're going to be showing it to you, because it shows you that these patients are really good in patching the eye. Again, this is an abnormal head posture. The doctor or the mother has to always remind the patient to keep a straight, and again, an abnormal head posture. So when you have a patient with strabismus, how do you go about the examination diagnosis? I cannot stress a thorough history. You don't have that now, but when you come into your fifth year, we're going to be teaching you how to do a thorough history, but remember that for your exams. Take the birth and medical history, the age of onset, symptoms, and family history. A thorough examination. We have to do an anterior segment examination, and we have to do a good fundoscopy examination. This is me here examining through a slit lamp. This is me here examining through a indirect ophthalmoscope, the one I talked to you about in the first lecture. So when we examine, I've already talked to you about it. Here is your normal. Can you see that? What we call the corneal light reflex. This is your normal. It's smack in the pupil. And here, unfortunately, it's normal here, and here it's towards the limbus. If it's going towards the limbus temporal, it means it's an esotropia. Again, I just show you, this is the normal light reflex, and this is the abnormal. It goes more towards the limbus or even the edge of the pupil. Then we have something called cover-uncover test. You don't have to understand how it's done, but just know that we do cover-uncover tests to be able to examine for strabismus. We use prisms. Again, these prisms are being used to try to identify the strabismus, and we also do a refraction. Remember, we talked about the refraction. We showed this in the instrumentation when we talked about retinoscopes. It's to identify the degree of refractions. All you have to know is three: hyperopia, myopia, and strabismus. The common refractive error in strabismus is hyperopia. How do you manage these strabismus? Remember we talked about hyperopia? Refractive error, get them to wear glasses. This child is smiling because when we put the glasses on him, he can see his mother for the first time. So he was so happy that he could see his mother. So we can do it either by glasses, we can do it by prisms, and sometimes orthoptic training, which I'm not too keen on. So the key word here, your first management is glasses, refract and put glasses on. Your second management is patching. Why do we patch? Remember when I showed you that nice photo of the eyes looking straight ahead? So if you have one eye that's actually turned in, what's the brain going to do? The brain is going to focus on the good eye and ignore the bad eye. Let me give you an example. You're taking your car and you want to go to a nearby town, let's say Kharj. And you have one street that is straight and you have another street that's curvy. Which one are you going to take? We're all lazy. We're going to take the straight street. That's what we do. We'll be taking the straight street simply because we're lazy. The brain is the same way. They have one eye is straight, the other eye is deviated, strabismus. The brain is going to concentrate on the straight eye and ignore the other, as you did for the street. But if I was to go back to the path or the street and close the good street and you have to go to Kharj, which street are you going to take? You will have to take the squirvy street. You will have to take the street that is not straight because you have to get to your place of where you want to go to. We do this same thing to the brain. We go and we cover the normal eye. The same way I covered the normal street. I am forcing the brain to use the squint eye, the strabismus eye, the abnormal eye, the misaligned eye. So what I'm doing is just simply forcing the brain to use the other eye, the same way I forced you to use the squirvy or the cricket line, the cricket street. Again, so this patient needed glasses and patching. This patient needed glasses and patching. We try to make the patching fun. So we put these nice, like this one has a spider, this one has a nice little girl, this one might have a clown, just simply. So when we patch, we are reducing or occluding the good eye, which activates the deviated eye. So that's what I'm doing. I'm occluding to force the brain to use the deviated eye. Again, it's only performed in children with unilateral deviation. So again, more, here's some mother very smart. She put a cotton patch, which I'm not very fond of, but it does the work. So let's talk here. Here is your normal eye. It's sending all these brain stimuli. It's sending all these stimuli to your occipital lobe. Remember, we talked about it. And then this is your deviated eye. It's not sending anything to the brain. So what I do is I go and I close the normal eye that's sending all these impulses to the brain to force the other eye to send these impulses to the occipital cortex. And again, here's another patient. Now, we talked about refraction glasses as the first mode, then we talked about patching. It could be both. If these two do not work, your next, those I consider medical, your next is surgical. Always remember that. If anyone asks you, this is an important as an exam question later in your OSCEs, what's your mode of treatment? Always say medical, surgical, then start. So this is your surgical. We actually do a surgical intervention. We do a recession and resections. Just say muscle surgery. That's all I need you to know. We just do muscle surgery. This patient had a deviated eye, as you see here. This is the normal corneal light reflex. This is towards the limbus. And when we did the muscle surgery, you can see nicely the eyes are still red from the muscle surgery, but interestingly now we got both eyes straight ahead. So we've sort of, another surgery is botulinum toxin, Botox. We inject, as you can see here, we inject Botox into the muscle. It's used instead of muscle surgery. a muscle is injected, as you see nicely here. The muscle is injected with a small amount of botulinum toxin, the Botox. It's usually temporary, and it results in straightening of the eye, interestingly, but it does need to be repeated. So we finished the medical, which would be the glasses and patching. We finished the surgery, which is actually the muscle surgery or the Botox surgery. So what's the importance of early strabismus detection? One, to prevent amblyopia, the lazy eye, to improve the cosmetic appearance. If you have an adult, usually they'd like to, and they're getting married or maybe starting college and they're a little bit sensitive, we can do it for cosmetic. It's to unveil a possibly underlying pathology. Not every strabismus is only due to muscles. I explained to you, it could be due to strabismus, it could be due to retinoblastoma, retinopathy of prematurity, many other causes, and strabismus requires immediate referral. So anytime you see a child with strabismus, please, remember we showed you, please get them to a ophthalmologist as soon as possible. Do not wait. Usually, I like to see the patients between 2 to 4 years of age. If once a patient develops strabismus and did not, unfortunately, get treated in childhood, they cannot be treated in adulthood. They develop something which we refer to, and I placed it here, amblyopia. In order to prevent amblyopia, we have to treat these patients 6 and downward. If we get someone who's older than that, usually the treatment is less adequate and less beneficial. So if you see anyone with a squint, please, please, please refer them and tell the mother you have until the age of 6 years for your child. So now that we talked about strabismus, and we said if it is not treated before the age of 6 years, that's what you have to know from the textbook, you develop amblyopia. What is amblyopia? It's due to a congenital or insufficient light stimulation entering the eye at a critical period of development. So this stimulation, as we showed, has to reach the brain, and it has to be in both eyes. Remember, we talked in the beginning, go back to your slides in the beginning, that it has to be both complete and symmetrical. So we try to avoid. Amblyopia is the unilateral or bilateral decrease of vision caused by form vision deprivation, meaning the light stimuli, as I showed you in the nice cartoon, does not reach the occipital lobe. It's an abnormal binocular interaction for which there is no obvious cause found by physical examination of the eye. When you examine the eye, there's no cataract, there's no corneal opacity, there is no retinopathy of prematurity. It's simply because the patient had strabismus, and unfortunately, it was not treated before the age of 6 years. Impulses were never sent to the brain by that particular eye. There's a dominant eye. This eye will be totally normal, but because the impulses were not sent before the age of 6, the patient will have a lazy eye, or what we like to refer to as amblyopia. It occurs in about 2% of all children. There's often a family history of this disorder. There's a reduced vision in one or both eyes. And just remember, this is the most important sentence, caused by visual deprivation. We did not send enough stimuli. The normal vision is usually imprinted in the brain in early childhood. I showed you the nice graph. Go back to it again. This is very important. If this process is interrupted for any reason, may it be strabismus, cataract, cornea, amblyopia will occur. It is reversible if treated before the age of 6. Sometimes we say 8, but I like the number 6. It's reversible with the appropriate treatment. This is before the age of 6. Lazy eye is often used to describe amblyopia. So we have something called strabismic amblyopia. I've talked to you about it. Remember, the vision has to be the same in both eyes. Unfortunately, because the eye has strabismus, we talked about, a misalignment, the child's brain will often select the one eye to view the world. Always, the brain is also lazy like us. Remember the street? They will take the normal eye, ignore the other eye, and it's unfortunate. The other eye will be suppressed, shut off, as I mentioned to you. It's the weaker eye, the strabismic eye. That eye is habitually deviated or crossed and is at a risk of developing amblyopia. And I think this picture shows it nicely. They should all be together because this eye is deviated. It goes here, it sees something else. So you develop strabismic amblyopia. There's also something called anisometropic amblyopia. This is when you have an abnormal refractive error. There is no strabismus. The eyes are the same, but unfortunately, one eye, this is the normal eye, this is the eye with the refractive error, the hyperopia. So the image is not being concentrated on the retina. It's actually here. So this eye never reached the macula, never sent. So again, simply because this eye has hyperopia, as you see nicely, as you see nicely here. So because this eye has the amblyopia, it's unfortunate, has the hyperopia, never concentrated. So unequal eyeglass prescription between the eyes. If the eyeglasses are not worn, then the eye that receives the more blurred image, the eye with the higher eyeglass prescription, is at risk for developing amblyopia. That's why we tell the mother, please, please forget what the neighbors say, what the grandmothers say, what the relatives. The earlier the glasses are worn, in fact, we like to let them wear before the age of 2. If they need glasses, let them wear it because they only have until the age of 6. I always do the comparison with, you feed your children until they are 18, 20 years old because they grow taller. Well, for the eye, unfortunately, it's only until the age of 6 years old. So after that, it's unfortunate. If they are not treated, they will not have normal vision. The same way, if you don't feed your children by the age till the good food to the age of 18, you can't expect them when they're 20 or 22. You give them good food, you expect them to grow. Their growth spurt is at 18, the eyes development and the impulses until the age of 6. All right, so, and then we have what we call the refractive amblyopia. You can either have high hyperopia, high myopia, and this results in bilateral amblyopia. So these are the classifications of the amblyopia. And then the most important is amblyopia by visual deprivation. Remember what we talked about? Something is not allowing the light reflex, as you see here, is not allowing the light reflex to reach the macula to go to the brain. So it can either be due to a cataract, it can either be due to a ptosis, it can be due to a hemangioma, and God forbid, a retinoblastoma. So all these cause amblyopia because the light is not going through the normal visual axis, as we talked about. So what's the treatment of amblyopia? Early detection. I cannot stress it. Early detection. The younger the age, the better outcome. So you treat them early. The treatment of amblyopia, if it's a strabismic amblyopia, patching, just patch. Patching is recommended. If it's anisometropic amblyopia, put the glasses on, proper eyeglasses. If there is a cataract or any other, what we call deprivation amblyopia, then you do surgery. You go in, you remove the hemangioma, you remove the retinoblastoma, you remove the cataract, you do a corneal transplant if there is a cornea. So it's really very easy. Let's spend just a minute or two on nystagmus. You hear that? Ra'a, the movement, the fast movement. This is an abnormal, persistent, rapid, involuntary, oscillatory motion of the eye, usually from side to side. It can be congenital or acquired. Another I'd like to talk to you about is retinopathy of prematurity. This is again occurs in, this would be under pediatrics. It's a retinal disorder found exclusively in premature infants. So unfortunately, these infants are born early. I used to do a lot of retinopathy of prematurity in my younger age. The incidence of ROP increases for younger and smaller babies. Eye examinations are usually performed in the hospital nursery. Can you see how small these children are? I can practically put them, this is me examining one of the little babies. I can practically cover his whole face with half of my hand, and the eyes have to be dilated. So we dilate the eyes, we're opening it here, and we examine them, and we have to treat them immediately at 6 weeks of gestational age, if you want to believe it. And sometimes we put even glasses on them early. Now, let's talk a little about leukocoria. This is the normal. You have your normal and your normal. Red reflex. Remember, we talked about the ophthalmoscope and the instrumentation. Each and every one of you should own an ophthalmoscope, and even for your own siblings, if you're in the ward, please always do the red reflex. This is a normal red reflex. This is what you should see when you put the ophthalmoscope. This is abnormal. When this is a nice red reflex, yikes, this is abnormal. That scares me. That really scares me. This is a normal. You can see a nice red reflex. This is abnormal. That scares the daylights out of me. I will tell you, when I see this, it is a retinoblastoma until proven otherwise. So I wanted to talk to you, show you the normal, forget now leukocoria. I wanted to show you the normal red reflex. This is a normal red reflex. This is an abnormal. This is an abnormal. So what do we mean when we say leukocoria? It's a white pupillary reflex. It's an abnormal white reflection from the retina of the eye. Can you see it? This is the normal. Parents will come to me thinking their child is bleeding, but it's not. This is the normal. This is the abnormal. Okay? Again, it's usually, for me, this is one of the primary signs of retinoblastoma. You can see it here. This is a pseudohypopian, simply because of the extensive and very, very advanced retinoblastoma. It's come in the middle of the eye to the anterior segment. And here, this is your whole retinoblastoma, lots of calcifications, obstructing the macula. That's why you didn't get the nice red reflex, because this white is actually the reflection of the retinoblastoma cells. So what's your differential diagnosis of leukocoria? Very important multiple choice questions. It can be a congenital cataract, primary hyperplastic primary vitreous. I'm happy if you say PHPV, toxoplasmosis, Coates disease, toxocariasis, and advanced retinopathy of prematurity, as I showed you when I examined the little children. So the retinoblastoma, this is the most common eye tumor in children. It occurs 1 in 15,000 live births. It's fatal if untreated. Early examination is key to survival. You can see this is, I did a 1-year pathology at the Armed Forces of Institute of Pathology in Washington, D.C., because I never wanted to be a pathologist, but I wanted to understand the basis of pathology so I could be a good clinician. And this was an eye that was enucleated and sent to me to actually be able to do the pathology on it. And you can see this whole globe was full of retinoblastoma cells. And see, when they enucleated it, God bless them, they took a lot. You try to take as much as you can of the optic nerve. This is it here, simply because of metastasis. So these are your presentations of retinoblastoma, leukocoria, strabismus, glaucoma, red eye, uveitis, as you see here, pseudohypopian, as you see here, proptosis, as you see here, can almost be like an orbital cellulitis. And here you also see a hyphema that we talked about. So how do you diagnose? It's a CT diagnosis of retinoblastoma. You will see calcification. You can even do it by ultrasound. Usually the optic nerve is involved, orbital CNS extension, and you can also get a pineal blastoma. So this is a matter of life and death. Thank you all very much for your attention. I hope that I have explained the strabismus and the pediatric ophthalmology in a very good way, a very simplified way. I tried to make it fun and simple because strabismus, extraocular motilities, is an important part and can be very complicated. Thank you all for your attention.